All right, so we're going to continue those lab videos from that pre-gait and midline orientation. And before I move on to gait, what I want you to hear is this, that when you are working on postural control and midline orientation, that postural control and midline orientation is static sitting balance. They have to be able to perform static sitting balance, which is essentially static postural control, before you can really move into more dynamic activities, which would be the midline orientation activities with the PVC pipe or the mirror, and into more dynamic balance training. Now, this is not contradicting what I said earlier. That decision tree is still the same. You start with static balance, and then move to slow reversals when the muscles activate, and then into more dynamic activities. So that still stands. So if we're starting gait training, we're going to do several different videos of gait. The first one will be gait in parallel bars, and then we'll have gait with a front wheel walker, gait with a hemi walker, and maybe gait with a quad cane. So we'll go from parallel bars into gait with less restrictive assistive devices. All right, so what we have done is all the transfer training. We have started gait. So you'll see that anytime I start gait with somebody, I want to do some level of pre-gait just to prep the patient for success. All right, Bryce, I'm going to have you scoot forward in the chair. There you go. All right. And then what I want you to do is push from the chair when you stand up. And we're going to stand up on 3, you count.
1, 2, 3.
Good. All right, so you can see, I will call his right leg the affected leg. Okay. And what I can do is either stand on the strong side if I want to make sure that if he loses his balance, I can support him on that strong side, or I can stand on the affected side. And I'm changing my mind. We're making right leg affected so you can still see me and you don't have to look at my backside for the whole video. So if I wanted to, I could stand on the unaffected side so I could help support that if he loses his balance. And I would do that in the earlier stages of rehab. Once he's confident and can do pretty fair support, then I can move on to the affected side to encourage that weight bearing with gait. So if I'm on this affected side, what I want him to do is start his pre-gait with some stepping. So I'm going to have you shift all your weight over to this affected side, yep, and then step forward with that right leg. Good, and step back. Good. So what I'm doing is using my own proprioceptive input. I'm feeling where his weight shift is occurring, and I'm paying attention to his body mechanics with that weight shift. So I can see if he's cheating by shifting his hips towards the affected side and just shoulders, right? And he's not doing that, so we're good. So this time, take a bigger step. Good, and now back. And on my right leg here that's supporting his leg, I'm not really forcing him into extension. I'm just providing some sensory input so I know also if he's buckling or hyperextending. All right, you ready to try walking?
Yes.
Okay, so if he is in this position, I can provide, honestly, anywhere from moderate to maximum assistance to contact guard, depending on the level of the patient, because I have good support. He's close to my body. So if he loses balance, all I have to do is extend that knee, pull him close to me, and then I can give him a cue to flex his hips and sit into his chair. Okay. All right, so first I want you to step with the strong leg. And I want him to step with the strong leg because I want the weight bearing through the affected leg. So now I can either guide or he can step with the unaffected side. So he'll shift his weight and then start moving that foot forward. If he needs help, I can help him. I want you to go a little further with that foot. There you go. And then I can still support from flexion or buckling. All right, go for it. There you go. Next step. There you go. All right. And then I could actually also incorporate backwards walking for hip extension strength if necessary. I want you to walk backwards now. Can you start with this leg, pull that leg back? Good. And now other leg. Good. this leg. Yep. And then the other leg. And tell me when you feel the chair on the back of your legs.
Now.
Now, all right. When you sit down, I want you to try to keep equal weight on both legs. So you're going to practice that same thing we practiced in sitting. So I want you to reach back with both hands for the chair and lean forward a little bit. And then bend those knees a little bit and start sitting down. Both hands on the chair. There you go. Nice and slow. Well done. Okay. So that would be gait in the parallel bars. If you are working on coordination or any other aspect of gait, you could potentially put takedown on the floor for Parkinson's to encourage that better sequence of gait, or to increase step length on the unaffected side. Remember that individuals who have an affected side, if they don't want to weight bear through their affected side, they'll take a short step and then a really long step with the affected side, and a short step and a really long step. So you can get them targets or talk them through with tactile cueing to increase the duration of time that they are weight bearing on that affected side, okay? To equalize those steps. All right, thank you.